Good afternoon, good morning, good evening, wherever you are. Welcome to the Pertussis for Pulmonary Time to DTap, Tdap. The main thing is I'd like to thank the Chest Foundation, who is doing in collaboration with Sanofi Pasteur, bringing this very important program to all of us. I think this is a very, very important and timely topic. But before I go into the introduction of the topic, introduction of the panelists, I like to take time to thank all the frontline workers, all the people who are pulmonary critical care, who have been practicing in the area of ICU or pulmonary, taking care of the patient, especially when the COVID crisis is here, the surges are here. And we just like to thank and extend our gratitude to all of you for doing what a great job for the patient care, always putting patient and service above ourselves. So thank you very much from ourselves, on behalf of panelists, on behalf of Chest Foundation and Sanofi Pasteur. Now let me go take a moment to introduce our excellent group of panelists. So I'll be serving as a moderator as well as panelist. Dr. Catherine Masio, she's Assistant Director and Clinical Pharmacist. She works in the Department of Ambulatory Care Pharmacy and University of Illinois, Chicago. She is does a lot of immunization program, and she's champion in that area. We have Dr. Subramanian. He's a division chief of pulmonary critical care, section chief in the specialty clinic at Southern Gold Foundation in California. Best of luck. Last time I talked to him, he was just getting inundated with the COVID crisis. I'm Dr. Salim Surani. I serve as adjunct clinical professor of medicine pharmacology at Texas A&M. I serve as the program director of pulmonary medicine at HCA Bay Area Medical Center. So let's dive into the topic, see why we talk about pertussis for pulmonary physician, why it is a time to Tdap, we'll try to go over the epidemiology and disease burden, clinical symptom prevention, and how to improve the vaccination rate among the adult population. What I would try to do is I'll try to cover some epidemiology and disease burden, and then I'll pass it to Dr. Subramanian to talk about some clinical symptoms and prevention, and then Dr. Masio is going to talk about vaccination, and then we'll try to sum it up. We have have some questions which we have got from a lot of our fellows, the other colleagues, the physicians. We'll try to address. But if you want to address any questions, you can put it in the chat box, and we'll try to get to as many questions as we can. What about pertussis? It's a very highly contagious acute respiratory disease caused by Bordetella pertussis. It's a gram-negative capsulated organism, diplococci. Worldwide, there is almost 24.1 million cases of pertussis and about 161,000 deaths per year. So it's a very serious issue. Approximately half of the babies less than 1 year old who get pertussis, they need treatment in the hospital. And a lot of the time, the pediatricians are very good in paying attention when they're looking into that. But what about the adult? And that is something which is neglected and ignored a lot, and we are going to try to bring into light what are the challenges we are facing. In 2012, CDC reported almost 49,000 cases of pertussis in the United States, but many may go undiagnosed and underreported. And we'll go and discuss further in the talk that since 1980, there has been an increase in the number of the reported cases of pertussis in the United States. And in 2015, the greatest percentage of the affected patients were adolescents and adults. That tells that we did a good job in vaccination. Are we doing a good job in vaccinating the adolescent and adult population? As we talk about, it's a respiratory infection caused by Bordetella pertussis. It has a multiple antigenic and biological active product. One of the things is anytime it's a very contagious and communicable disease with an attack rate of 80 to 100% among susceptible household contact. So what happens is anytime the bacteria come in, they go into our airway, and the filamentous hemagglutinin along with the protectin and fimbriae try to bind the cilia. And once they bind the cilia, they try to inactivate that. And what happens is that the pertussis toxins is kind of then do the destruction phase. But before even that, you have a tracheal cytotoxin, which tries to kind of immobilize the cilia. And the pertussis toxin goes ahead and inhibit the G protein coupling mechanism, which regulate your adenocyclase mediated conversion of ATP to cyclic ANP, and that actually impairs the phagocytic function and cause a real big challenge. The clinical course from the exposure to initial stage, the patient has a catarrhal stage, which is non-specific upper respiratory symptoms, and then around within first several days, the patient start having a paroxysmal attack of cough, whoop, and vomiting, and it goes on up to 6 weeks. And then you have a convalescent phase, which cough decrease in frequency and severity, and some of those will be discussed by Dr. Subramanian further along the course. What about the thing is that, is the pertussis in adolescent and adult age, is it affected really by some other disease? Or is it some of the disease which we have increase the risk of our getting the, if we get pertussis, increase the risk of our hospitalization? The study by Sarah Mabel, what they did is they looked at the enhanced pertussis surveillance in 7 US states, and out of 15,942 patients, 515 were hospitalized. But when they look at it, the US average rate of asthma and COPD admission, the asthma admission rate was in adolescent was 10%, but when we look at the patient who had the pertussis, 44% of them, they got hospitalized. When we look in the adult with the asthma 21 to 64, the average US asthma admission rate was 8%, whereas if they had a pertussis, their hospitalization rate was higher. And adult with the COPD, 6% US average rate of admission, but 15% in the case when they had a pertussis. And the people who were admitted in the hospital with pertussis, they had a higher length of stay. And we know that how much pressure we face in the length of stay in this time and age. Not only that, these are challenges which we see in the patient with COPD and asthma, but again, it is also increased risk of pertussis in the obese individual. The same paper by Sarah suggested that there was an enhanced pertussis surveillance program showed 52.6% of the adults who were in the range of 21 to 64 were obese. And also there was an increased risk of pertussis or hospitalization in an individual with a BMI of greater than 30. So I live in South Texas. I think BMI of 30 is good. So, but that puts us in a very big risk for all the challenges. Again, if you are immunocompromising condition, 34.8% of the individual, they had some challenges and increased severity of pertussis. Again, 34.2% of the individual who were a smoker were getting those disease. So not only COPD and asthma puts us in a risk, obesity, smoking, and immunocompromised status puts us in a risk. There's been an increase in incidence of pertussis. We know that a DTap came in, and well, the main thing is that this is the one which the children are getting, and then we start having a Tdap vaccine for the adult. But what we saw was the incidence, which was very, very low in 73, then it started creeping up. And since 1980, we saw increase. And by 2015, instead of having less than 1 case per 100,000, we were having 15 cases per 100,000 in 2012. And a lot of those we are finding were in adolescent and the adult population. One of the things is the pertussis affects all age group, but can be frequently overlooked. So we know that if there are infants, greater than 40% of the infants who are less than 6 months of age with pertussis are hospitalized. So we are very well aware. The pediatricians are very well aware. But what happened? A lot of the time we kind of not think about this condition in the adolescent and adult, and this sometimes can be confused with a lot of the other viral infections and other bacterial infections, and it goes into the challenge. The main thing is, again, in the adolescent, the illness is not like a typical whooping cough, which we see especially in the children, and it's less frequent. But again, if you don't recognize and if you don't diagnose it, that leads to increased hospitalizations and the challenges related with that. So again, what in adolescent and adults, it is still sometimes unrecognized, and also untreated pertussis can pose a risk for transmission to the others. Now, taking into the area of clinical diagnosis, I'll pass it to Dr. Subramanian to take it from here, and we'll see what he teaches.
Thanks. Thanks, Dr. Surani, and good morning, good afternoon, or good evening to all of you. And I really appreciate all of you taking time and participating in this webinar. I appreciate Sanofi and the CHEST for putting it together. So continuing from where Dr. Surani left off with clinical diagnosis. We'll talk about the clinical presentation, and then we'll sort of move on to the vaccination piece of it. So Pertussis, one of the things that probably accounts for a increase in prevalence could be that we are starting to get a little better at diagnosing this, although my suspicion is that the clinical criteria here are not well understood by most people, and so there may continue to be a significant underreporting or underdiagnosis of pertussis in the general community. So how exactly should we, particularly as pulmonologists treating majority adult patients, diagnose pertussis? How do we know which of our patients with chronic cough may have, or acute or subacute or chronic cough have pertussis? So for adult patients who are complaining of either acute or subacute cough, and we typically differentiate that based on a 3-week or less duration for acute cough and 3 to 8 weeks for subacute cough, we are asked to focus on 4 key characteristics. One is the cough of a paroxysmal nature? Is it sort of more sporadic, comes and goes, or is there paroxysms or repeated spasms of coughing? Secondly, is there post-tussive vomiting? That could be an important clue. So if the patient and that is a very, very specific kind of a clue that, every time that I cough, I end up throwing up. That could be a pretty significant thing. The third is the sound, the whooping sound itself. Most of the times patients, when you ask them if they cough, they will try to go into an elaborate demonstration of their cough in front of you. And most of the time that has very limited diagnostic value. It is they just psychologically do it. But this is one instance where if you hear that very characteristic whoop, that could very well be a clue that this patient may have pertussis. And then the other thing is the absence of fever. That is a negative finding, but one that rules out other causes of subacute or acute cough rather than pertussis. So there is 3 different sets of criteria, one by the WHO, one by the CDC, and the other by the public health in England. And this table, it's a bit of a busy slide, but it lays out exactly what the criteria are. So it starts off with a patient being diagnosed clinically by a physician. Again, you start off with not having a ready cause. So obviously, if you have somebody with an acute cough and he clearly has pneumonia or community-acquired pneumonia or some other reason that you can immediately identify, maybe he's on an ACE inhibitor, things like that, then that's that. But if you have unexplained cough that has been lasting for over 2 weeks, in England they say 14 days, but basically over 2 weeks, and if you have one of these things, so if you either have inspiratory whooping, or if you have post-tussive vomiting, or if you have a paroxysmal nature in the cough, then either of these 3, in addition to an unexplained cough, would pretty much get you into a diagnosis of suspected pertussis. And so if you look at, if my patient doesn't have the post-tussive vomiting and doesn't have the characteristic whooping, but he does have paroxysms of coughing, then that itself would be enough with the other criteria, as long as the cough has been there for more than 2 weeks and there is no known cause and there is no fever. Next slide. In terms of how would I confirm it? So confirmation can be by culture, which is agreed upon by all the 3 organizations, either culture or PCR of a nasopharyngeal swab. And then in England, they also include serology or oral fluid testing. There is less agreement, particularly with the CDC, not really recommending that. Next. And so if you look at what is the sensitivity and specificity of all of these things, you could see paroxysmal coughing has an extremely high sensitivity, probably the highest of that at 93%. The whooping sound and the post-tussive vomiting have very low sensitivity, relatively speaking, only about 29 to 30% in adults, much more so in children, but certainly not much in adults at all. And the absence of fever is helpful because that also has high sensitivity. On the other hand, if you look at specificity, we almost see the exact opposite. So the paroxysmal cough really doesn't have much specificity at all, whereas post-tussive vomiting and inspiratory whooping have very high levels of specificity. And so then you can kind of use these sensitivity and specificity values. And then, of course, your likelihood ratios will also depend on disease prevalence, but those are sort of less useful to know. I think it's more useful primarily to focus on where do you draw the line as far as sort of the sensitivity versus specificity as far as making a clinical diagnosis in adults. And I mean, the annual costs are significant. And again, my own bias is that these are probably underrepresented because pertussis continues to be underdiagnosed in the community. But even with the confirmed, pertussis carries a tremendous healthcare resource utilization burden, a tremendous economic burden that totals millions of dollars in total costs. So something certainly that if we can move the needle on by better diagnosis, more early diagnosis, and most importantly, by vaccination, we can really make a tremendous improvement in reducing these humongous healthcare utilization costs. Next slide. So again, overall, the clinical impression is the most accurate predictor. So when you diagnose pertussis, you are going to be making a clinical diagnosis. You are going to use whooping or post-tussive vomiting as the most specific criteria. However, they may not be very sensitive. And so sometimes you may end up using paroxysmal coughing or the absence of fever in the absence of having these low sensitivity whooping and post-tussive vomiting. So clinical impression overall is the most accurate way. And so I'll kind of list out the key recommendations for practice. This was born out of a systematic review by Ibel et al. Which was published in 2017. And so it's, again, a bit of a busy slide, but I'll try to highlight the key features here that you want to obtain a nasopharyngeal specimen for culture and PCR, and that has a relatively lower evidence C rating. You want to treat with the intent of microbiologic eradication and also reducing transmission. The clinical symptoms may not improve dramatically or quickly, and so this is something that physicians should keep in mind. Macrolide antibiotics are the preferred agent for the treatment and prophylaxis, and that has an evidence A rating. If they cannot tolerate a macrolide, what is the alternative? So the two alternatives are Bactrim or trimethoprim sulfa or clindamycin, and that also has an evidence A rating. And in high-risk exposed patients, family members, let's say elderly, those with COPD, morbid obesity, as Dr. Surani was elegantly talking about, then you may want to consider antibiotic prophylaxis, and especially so during epidemics. If there is a rapid spread of pertussis or a known spread of pertussis in the community, you want to be using that. And then, of course, the vaccination piece of this, Lee Mosio is going to be addressing very, very shortly. Next slide. This is an important slide, especially for, obviously, we are right now, having, this humongous once in a century or once in a lifetime of a crisis of COVID-19, and the flu season is right upon us. And so as we enter into wave number 2 or 3 or 4, I think we are rapidly, unfortunately, losing count of exactly how many waves are hitting us. And as the next influenza epidemic starts, this is probably a very important slide for all of us to really review and familiarize ourselves with the clinical features and differentiation of influenza versus COVID-19, and then for the context of this talk, Pertussis. So symptom onset tends to be abrupt obviously with influenza and COVID-19, but is a little more gradual with Pertussis. So remember, these are patients who have 2 weeks, sometimes a lot longer, of just a persistent cough. Fever is typically mild and only in the early phase in Pertussis. Remember, one of the criteria in terms of diagnosis was actually the absence of fever. And instead, in influenza and COVID-19, fever is very common, often quite high. Body aches and muscle aches and fatigue and weakness, those types of, being down with the quote unquote flu, really a very characteristic symptom of influenza. Not so common in COVID, although with COVID, there is a lot of variability with regards to those systemic features. Stuffy nose, runny nose, often seen in early Pertussis and COVID, sometimes seen in influenza. Then we get to the cough itself. The cough tends to be non-productive and of moderate intensity, sometimes worse at night, but very, very rarely so. With Pertussis, it's initially intermittent and then starts to become much more paroxysmal, can have that characteristic high-pitched whoop. And nighttime coughing is actually very frequent. So if you do have patients who have nighttime coughing, that should also be a clue that, especially if it comes in spasms and with the whooping sound. And with COVID, of course, you have coughing, and then you also rapidly, unfortunately, start having dyspnea as it starts to settle into COVID pneumonia. Sore throat can occur early on in COVID-19, uncommon in Pertussis, and sometimes occurs in influenza. And the infectious period in influenza is 1 to 2 days before symptom onset and 5 to 10 days after. With Pertussis, it's from before the cough begins to 21 days after the cough starts, or until 5 days of antibiotics. And with COVID-19, they have an incubation period of 2 to 14 days. Most patients, the peak infectiousness for the patient or peak infectivity tends to be on with onset of symptoms. GI symptoms are specific mainly to COVID-19, with vomiting and diarrhea well known in a significant percentage of patients, and those are uncommon with influenza and Pertussis. And of course, the anosmia and loss of taste and smell, not on this slide, but that is certainly something that is specific for COVID-19, not really a feature as much of with Pertussis and influenza. So next slide. And so this is the recommended oral treatment. We already saw, the azithromycin or clarithromycin being the drug of choice. We'll focus on row number 4, which is adults, for the purpose of the talk. And again, 5-day course of a Z-Pak. Clarithromycin, you use it for 7 days. And then backup agents, that is the dose, 14 days of trimethoprim sulfa. Clinda is another alternative if they have allergies. Next slide. And so I'll hand it over to my co-panelist to talk about and walk you through the rest of the presentation that focuses on the vaccination and its importance. Catherine?
Good afternoon, everybody. Thank you. Thank you, doctors. Thank you to my colleagues here on the panel. And also thank you to the Trust Foundation and Sanofi for inviting me, a pharmacist, to give you some information on vaccines and prevention of the disease. So we're going to just jump right in and talk about the rest of the talk about, what are some prevention strategies? And as this slide kind of concisely describes, we know we have a vaccine. We have a few vaccines for infants, adolescents, and adults. And we know that there's quite a value in using these vaccines in a prevention strategy. We have this obvious COVID pandemic going on right now. And as my colleagues already discussed, it could be initially very difficult to diagnose between the differences between COVID and the other respiratory type of infections that are going around this time of year. So how can we leverage some vaccine utilization, especially in the adult population during our pandemic that's going on? And of course, we already mentioned and touched on how I'll talk about Tdap, but adult pertussis vaccinations is relatively low, and how can we learn some strategies in our practices to start capturing a little bit more vaccinations for pertussis. Next slide, please. So we know that we're really good at capturing vaccines in infants and even adolescents. This slide kind of depicts the fact that we're pretty good with adolescents even getting that booster shot in between the age of 11 and 12. And then even between the adolescent years of 13 and 17, if they're still coming in for their annual appointments, we're doing okay in terms of an average of just under 90% in Tdap coverage. And Tdap is the vaccine that, just to clarify, is the vaccine that's utilized in age 10 and over. However, when we look at adults, and if we look at how well we're doing with Tdap vaccination coverage with adults age 19 to 64, on average is about 30%. Also, in comparison to the influenza vaccination, just under 40%. So we know that we can do better as providers in making the recommendation and also capturing the Tdap vaccinations. Next slide, please. Thank you. So what are some strategies? And we broke it down into kind of 4 pillars here, and maybe this is common sense, but a good review always helps. And number 1, providing convenience and easy access. So right now, I know in our practice here at the University of Illinois, we are trying to capture this time of year flu shots at every visit, regardless of the visit type. You know, could we possibly leverage that patient visit to encourage and review the Tdap vaccination history for that adult patient? And also this time of year, especially because we're trying to decrease the burden of co-infection with patients with comorbidities, can we review the Tdap vaccine history for the adult? And that kind of segues into number 2, communicate with our patients. Are we doing a good job of talking about pertussis disease as a whole? I know this time of year we always talk about flu, and maybe most of the general public says, you know, yeah, I have the flu, and or I have a cold, and now of course we're very concerned about COVID. But maybe sharing the typical things to look out for that should, when the patient should seek medical attention, and communicating with our patients, training our staff to discuss pertussis disease and also the vaccine that is available for it, that could increase awareness. And number 3, enhance systems to facilitate vaccination. So, you know, do you have the infrastructure, the staffing, even the EMR record system to support increased vaccinations? Some of our intake procedures could perhaps be part of a quick medication reconciliation, but also do a quick check of adult vaccine history. I know in some states there's state registries for adult vaccinations that are required by law, and then some states there aren't, but are we keeping good or setting ourselves up to be able to facilitate an increase in vaccinations for pertussis in adults? And then finally, getting motivated. This kind of seems probably a little bit too difficult to manage sometimes when we're super busy, but at the very least, we know that this is something that is not paid a lot of attention to. How can we motivate our providers and even our nursing staff and supportive staff to be able to ask about pertussis vaccine in our adults? And we do know in some, and maybe we touched upon it or we will shortly, there are, sometimes this is payer driven as well in some of our practices to meet certain vaccination benchmarks. So getting motivated is probably the first nice place to start in each of our individual areas that we work. Next slide, please. So I'd like to apologize on this slide. Please ignore the line that says box 3, but this is just a slide just to quickly go over the adult vaccine recommendations for pertussis. And for age 19 and older, regardless of the interval since their last tetanus or diphtheria, tetanus, or toxoid-containing vaccines, there's some doses, or some vaccines with without pertussis, but pertussis itself in a vaccine doesn't exist. So we do give Tdap, and then to ensure the continued protection against tetanus and diphtheria and booster doses for pertussis, it's recommended to at least give it every 10 years of throughout the adult life. And now I will hand it back to Dr. Serrani.
Hey, thank you, Dr. Masio and Dr. Subramanian. One of the things is, let's try to sum it up. We heard about the epidemiology, we heard about the clinical symptoms, we heard about the vaccination. What are strategies we can do, to increase the vaccination rate? We know it's a very highly contagious, very highly infectious disease, and it can cause a significant morbidity and mortality in the adult population. The vaccination coverage among the adults and adolescents we saw remains relatively low, and again, it definitely needs improvement. Now with the COVID vaccination coming in, everyone is now gung-ho about getting some form of the vaccination. Can we try to improve some of the vaccination rate? Because you don't want to have 2 or 3 respiratory illnesses going on at the same time. You don't want to have a flu and COVID. You don't want to have a pertussis and COVID, because we know that that is going to compound already existing challenge which we are having with a patient with a pulmonary disease like COPD and asthma. So there are certain evidence-based strategies we can definitely incorporate into our clinical practice to increase vaccination rate in adolescent and adult. That can be like, try to discuss with the patient, provide convenience and easy access, try use every visit, as an opportunity to vaccination to the patient, offer the vaccination at the time of when you're giving a flu shot. Also try to take into some of the presumptive approach rather than participative approach, because that seems to be worked pretty good. Try to enhance system to facilitate, as Dr. Masio was saying, use us as a standing orders in the EMR order, and set a good example. Get yourself vaccinated. So that's the key thing. Now let's try to sum it up now, and then we can try to, after that, go into a question and answer. And we have been getting some interesting questions, and we'll try to throw it out to panelists and also take some of the question myself. But let's sum it up. We learned that it's a very highly contagious acute respiratory disease caused by Bordetella pertussis, which is a gram-negative diplococci. We know that the number of the cases has been on a rise since 80, and something we need to do about that. We know that adolescent and adults are a lot of the time unrecognized or untreated pertussis, and that can pose a lot of risk of transmission. And they can start passing it to the children and everyone around them, because it is a very contagious disease. Tdap coverage among adults in the United States is very, very suboptimal. And there is an increase in the Tdap vaccination need in the adolescent and adult population that can help us protect against the pertussis. So having covered that, sum it up, I'll try to now open the things for the question and answer. I'd like to thank again all our frontline workers, all our physicians taking care of all our patients and keeping the patient first and always service above self. And I think that's the key factors which we are going to look into it. One of the things is that, please use the chat box. We'll try to get to as many questions as we can. As we are getting some questions, my first question is to Kathy. Someone is asking, what is the difference between DTap and Tdap? So D is capital, T is capital, P is capital, and then in Tdap only T is capital. The other ones are the small case letters.
Yes, so maybe we can just cover some basics, because this is very commonly confused. And so just really quickly, if we're talking about capital D, capital T, small a, capital P, that's for the infant series. And, that's only used in age 7 and below. And then we flip to the adult, and that has a higher level of antigens for each of these 3 components of the vaccine. And as I said earlier, unfortunately, we don't have a single pertussis vaccine yet. But for adults, then we have capital T, small d, small a, small p, tall p. And this is only used in adults, age 10 and above. So just a good way to remember that is just, unfortunately, we do have to think about the diphtheria and tetanus portion of the vaccine, but the capital T is only used in adults.
Thank you, Kathy. We won't get you off the hook. We got another question from the audience. And, one of the things they're asking, why vaccine compliance for Tdap is so low? Or in other words, they're asking, what are the current barriers to the low vaccine rate? So I'll start with you, and I'll ask the same question to Dr. Subramanian and try to get his opinion.
Sure. I mean, if I may give a pharmacist perspective, we do know that in general, in adults, we don't offer vaccinations as frequently as we should. And this happens to be a vaccine that even pharmacists can administer in, I think, almost all states under a standing order of a physician. So I think it's just, we're so focused on children and adolescents and only certain populations of adults. We just probably could do a better job in terms of awareness of pertussis and, of course, the vaccination. I think in just barrier-wise, from my perspective, there's a lot of different things that could be it. Some of it is just where we work and if we have the accessibility, such as a standing order, and vaccine access sometimes in some of our areas is difficult if we work in an urban area versus a rural area. So those are some of the barriers that I personally have experienced in our field.
Dr. Subramanian, you want to chime in some?
Yeah, thanks, Elaine. No, I think definitely there is multiple layers to why this may be so. I think first and foremost is a lack of education or awareness. You certainly run a busy fellowship program, and I think probably you could attest to the fact that this isn't something that even during routine fellowship in pulmonary is really emphasized as much as say compared to influenza vaccination or pneumonia vaccination. And so the knowledge levels amongst the community physicians or even those who are freshly coming out of training isn't really very highly focused on pertussis as a prevention strategy relevant for a pulmonary practice. I think the second layer is, most changes in physician behavior, even if there is education, even if there is information available to them, most changes in behavior take place either with a carrot or a stick. And so unlike with flu shots, for example, where you want to be in the hospital, you need a sticker on your badge that says, I got my flu shot. You don't have really any penalties, nor do you really have any bonus brownie points for talking to your patients about pertussis vaccination. The same way you have for example, for pneumonia shots. That is one of the quality criteria that large health systems such as mine and most other health systems around the country are utilizing to say, how many of our primary cares are talking to patients about pneumonia shots and flu shots. And so I think it is time to maybe elevate the status of pertussis vaccination, to bring it onto the radar, maybe if not for everybody, at least on to those really high risk populations where now with electronic health records, we could easily proactively identify, these are all the COPD patients, these are all the patients with asthma, these are the patients who are high risk. And given, again, though the significant healthcare resource utilization costs associated with untreated pertussis or with pertussis spread, and compounded, like you said, Salim, with the ongoing COVID epidemic and influenza, and probably the triple threat now with pertussis, influenza, and COVID, this may be an opportune time to actually put that on everybody's radar.
Well, thank you, Dr. Subramanian. There is another question which seems like it's for you and me both together. So the question is that when does the primary care provider should refer the patient to the specialist? Let me tell you, one of the things is this is a very different time where we are, in the midst of pandemic with, we have a flu season going on. We have a COVID, we have a pertussis, which can cause challenge. And obviously common cold is there, as Dr. Subramanian mentioned. I think in this case, if somebody is having a cough and shortness of breath, I think you definitely need to make sure you get the COVID testing done. The history is very important because I think if you have the immunization in the child, but you haven't got any adult Tdap shot or in the adults, then is it for your time for the whether you have been adequately vaccinated? So the history will tell you a lot of information whether that can be done. Sometime in the adolescent or adult, the whooping is kind of not really that prominent, but the fever, if it is there, that will point you towards the influenza and the COVID, whereas the whooping cough, the fever goes kind of against that. But anytime you have a patient with a cough and a fever, or sometimes you have some vomiting and nausea, I think you got to be evaluated again. And I think, if there is any evidence of any shortness of breath or any infiltrate in the x-ray, this is a time where I think you need to get the evaluation done. And sometimes they may need to get a multiple test done to come to the right diagnosis, because sometimes even though we have a sign and symptom, but sometimes they cross the path with each other and it can be challenging. So I'll see what Dr. Subramanian, what opinion you have on that.
Yeah, no, I completely agree, Dr. Surani, and I think one of the questions that just came up on the chat box also talks to almost the same thing, which is to comment on overlap of symptoms between pertussis and other conditions, and sort of pretty much along the same lines of what you were talking about is, reviewing the clinical features. Now, there is obviously chronic cough with nocturnal worsening, could be seen in asthma, very classically could be seen in reactive airways disease. There's a lot of post-COVID reactive airways disease that we are now starting to see, patients who developed COVID 2 months ago and now have a very classic post-viral reactive airways disease with a lot of nocturnal worsening. So the absence of fever, the nocturnal worsening, and the paroxysmal nature of the cough, those to me are your best bet because of just how highly sensitive they are. Even though there is a relative lack of specificity, I think in adults, I just don't see as much of the whooping, the characteristic whooping sound or the post-tussive vomiting. If it is there, it makes it extremely, extremely likely. But most of that overlap that you're going to be seeing is when you don't have the post-tussive vomiting and you don't have the you don't have the classic whooping sound, but you instead end up with an afebrile patient with paroxysms of coughing, worse at night. And I think that is where the differentiation between reactive airways disease and asthma and cough variant asthma and that to sort of continue on what Dr. Surani was talking about, that might be a good patient to refer to a specialist because it may make a big difference in terms of how you approach the patient and treat them. Oftentimes patients end up getting a Z-Pak anyways, and maybe they end up inadvertently getting treated for pertussis without even being formally diagnosed with it.
So we go from the reflex, keyflex to the Z-Pak. But let me ask you, there's another question which came in, and it's kind of a two-part question. So I'll put the first part to you, and then I'll have Dr. Mercier address the second one. So they're asking, the bordetella pertussis is a respiratory illness, and the COVID is a respiratory illness. And you have addressed and touched on it a little bit that both of those are respiratory pathogen. How important you think it's for the people to take this condition seriously and try to prevent any other respiratory infection which can be making the COVID-related respiratory infection more complex? And follow-up question with Dr. Mercier is that do you think that the people should take this opportunity to get themselves vaccinated against Tdap and flu while even waiting for the COVID vaccination? So I'll start with Dr. Subramanian and then pass to Dr. Mercier.
No, I think yes, Dr. Rani. I think what you're alluding to earlier is that this is a very critical time for all of us, especially for patients with pulmonary issues, and they are already at risk for developing COVID, pneumonia, much more so. We already know that, and so anything that we can do to calibrate that risk down and prevent patients from developing respiratory problems and potentially developing. I mean, there are serious complications of pertussis that can sometimes occur, especially in vulnerable hosts, and keeping them away from healthcare facilities where they may get admitted or have to come to the emergency room because of severe paroxysms of coughing would be important. So certainly no question that any steps that we can do, this is probably the most opportune time to really elevate the dialogue about pertussis and bring about that awareness in the community. So to that extent, I think this is a very timely presentation by Sanofi and CHEST in sort of helping in that effort to some extent.
Dr. Mosius, you want to say something?
Yes, I mean, I couldn't agree more. It's a perfect time right now. We do, as providers and even the media does a great job at promoting the flu shot this time of year. The CDC, as we all know, do a fantastic job increasing awareness about the flu. But unfortunately, we don't hear a lot about pertussis and how to prevent it. So we underutilize this vaccine, especially in our adult populations. And I think it could start with providers and educating our patients about, while you're here in our visit, we know that we're going to give you a flu shot, but we're also going to give you a pertussis shot. They can be administered at the same visit. It's recommended to give it in two different arms, not in the same arm, so that if there's any localized reactions, we know which vaccine probably caused it. There's no contraindication in giving both vaccines at the same time. So I do agree. I think it's the prevention is key here. We know that the COVID vaccine is coming soon. We don't know exactly when, but soon. But when the vaccine is available now and we have the resources and tools to administer and recommend now, this is pretty important for the obvious reasons that we've already discussed.
Thank you very much.
One question from Dr. Dharani that I'll take, Dr. Rani, that is on recommending routine testing so just as a reminder to anyone, feel free to type in your questions on the chat and we'll try to get to as many of them as possible. So Dr. Dharani Narendra asks about recommending routine testing for patients and for pertussis in patients with subacute cough. And so just as a reminder of when I touched upon this, the recommendation, at least from the CDC, is not necessarily to routinely test everyone. The diagnosis is much more a clinical diagnosis. You don't necessarily need that PCR, but I would certainly test it, especially in today's day and age. You're going to be doing COVID testing on these patients with subacute cough. You're going to be getting a flu shot, testing for flu. So sending those nasopharyngeal aspirates for PCR or for culture, I think is extremely important in today's in these times where you probably want to make sure that, is this COVID, is this influenza, or is this pertussis? So that certainly is important.
There is another question which came in. Why there is an increase in case of pertussis after the 1980s? There can be several reasons. One is that it's just the nature of the normal human turnover. The other factor is that maybe it's a fading immunity of the vaccine and people are not getting immunized. We know that the immunization rate in the adults remain very, very low. It's in the 30s. The other factor can be also is that we are kind of having increased surveillance, increased recognition of the disease. So I think it's a multifactorial, but I still believe that the immunization lack in the adult and the adolescent population is kind of a very important factor, which is causing that area. There's another question I see is, does the vaccinating the adult patient with Tdap during influenza season improves the quality measures? or, we all talk about the health grade or quality, like if you vaccinate, does the hospital even get some benefit that, they can show the improved compliance and show that they're doing something? Is there anything like that which they get a credit or a point? For Dr. Subramanian?
Not as far as I know, Salim, but I think maybe something that we need to sort of push for. Certainly, both of us have previously been on the practice operations at just as chairs, and this may be something that we should probably start putting on the radar in our own networks and communities to sort of advocate for pertussis vaccination to be one of a critical quality measure. And I think that $180 million healthcare resource utilization costs of pertussis, it may just be the tip of the iceberg that convinces healthcare systems and payers and more importantly, Medicare to probably start including or paying attention to it.
Yeah, also that's a great point. We need to do more, but they actually start doing something in the healthcare matrix where, if you're immunizing, you do get certain points. So at least pushing for immunization, at least it's coming in the pipeline. How we can make it happen that, we can actually encourage the system change and make it more robust. So that's an excellent point. And I think, coming into the same line of immunization, we see another question is that's for Dr. Masio, as what is the difference between the presumptive and participatory approach? Which one is better? Where we can improve the immunization when the patient is coming to our clinic? How we can make it the best out of it?
Sure. So I think going back to strategy and trying to promote the immunization and prevention of the disease, we do see some vaccine hesitancy in some of our patients. But I think as providers, we could not only make the recommendation, but, educate and be able to communicate this information. So the presumptive approach would more be during a visit, you say something along the lines of, we have some shots to give today. While you're here, we're going to recommend the flu shot. And by the way, I noticed that we don't have any records of your pertussis shot. And, of course, looking at the history of the patient and not only vaccine history, but the comorbidities and risk factors, making that recommendation. If we're talking about flu a lot, why not talk about pertussis, especially during these times, versus the participatory approach would be maybe not as direct, maybe not as, it won't be too much of an influence. An example of that would be more of, there's some vaccines today. It looks like, we don't have any records. Would you like it today? And making it more general and without any education pieces and helping the patient understand the importance of the pertussis vaccine. So I think we have a little bit of work to do, but I also think it's just a new train of thinking, especially right now.
Thank you, Dr. Masius. Thank you, Dr. Subramanian. Thank you for all the audience. And also, I think I'd like to take this opportunity to thank Chest Foundation and Sanofi for bringing this very, very important topic in light, especially in the time where all the respiratory pathogens are going. And I think, in the interest of time, I think we will kind of stop, but thanks a lot for sharing all the very important and good questions. It also gives us some food for thought, how we can even interact with our patients, how we can make sure that we address these important issues, and how we can make our patient care even better. Thank you all for joining, and looking forward towards visiting with you all at some other platform. And you all have a wonderful day. Good evening, good night, good morning, good afternoon, whichever time zone you're on.
Be safe, everyone.
Be safe.
Thank you.